Good morning. On behalf of the UP Arthroplasty Society, I, Dr. Anand Nigam, welcomes you all to the 13th CAWNPORE Arthroplasty course. Last time, we conducted this course online. Though we learned a lot from the faculties that time, but indeed it was an online course, and it was like a learning swimming through correspondence course. But this time, we dived into the river of academics to dig out the pearl from the base, and that's why we are here. While going through the online courses, we decided why not to learn through a virtual reality platform. And this time, we converted the virtual reality into a true reality, the details of which will be narrated by my senior friend, Dr. A.S. Prasad, later on. We tried our level best to make this course a landmark course, but without the input and feedback of you people, it was not practically possible. And thank you all for being this, giving us the input. The basic thing, what the motto of our conference or our course since 2005, it was very beautifully narrated by Mrs. Indra Nui in his farewell speech. And there were three things which are a motto of this course also. The first thing is that being a lifelong student. Every time when we were young, when we were kids, then we had a curiosity, why the sky is blue, why the grass is green, why the birds fly. As we grow older, somehow whatever the reason may be, we lose the curiosity. But as a professional, I think we should never lose the curiosity. Because once we achieve a professional level and we think that we are satisfied with it, I think we are going to atrophy. Therefore, it's basically for us, howsoever senior may be a lifelong student. That's the first thing. Second thing is, whatever you do, put your head, hand, and heart into it. Take your profession as a calling, as a passion, and you enjoy it. Unless and until we enjoy our profession, we are not going to make an academic excellence into it. And third and the foremost is that help others to rise. When we are at a certain level of excellence, certain level of professional satisfaction, then it is our moral obligation to bring the youngest up, to fetch them up, to share the platform, and to achieve a more excellence than us. Only then we will feel proud of it. I think these are the three basic mottos which we are thriving on since 2005. And that's the basic purpose. Now, everything is not possible because of our core team. They work day in and day out since the very beginning. And despite of all oddities of COVID and its aftermath, they worked and to make this program a reality. Now, I call upon Dr. S. Prasad on the dais, Dr. Vishal Agarwal, Dr. Vinay Gupta, Dr. Loken Singh, Dr. Rajesh Jain, Mr. Rajiv Bajpayee, Mr. Ashish Kapoor, Mr. Sanjeev Jaiswal. I think this is the sum of the core teams. I think this is not the total core team, but beyond that, because this is the team, with all the oddities of all the things making this conference into the reality after the COVID aftermath, we are here in front of you. And it will be very difficult to narrate in English. The only thing which I can say is that आज बादलों ने फिर साजिश की, जहां मेरा घर था फिर वहीं बारिश की. अगर फलक मीन्स स्काई, अगर फलक को भी जिद है बिजलियां गिराने की, तो हमें भी जिद है यहीं पर आशियां बनाने की. Thank you to my core team. Now I request Dr. S. Prasad to give the brief narration of this course.
In 2005, we have trained almost more than 1,000 young doctors in the field of arthroplasty from this part of India. Now they are all practicing, they are doing a lot of things. The number may be less, but outcome, they all want to have a good outcome. Our endeavor is to show the right solution. So there are so many ifs and buts. So how you can evolve, how you can get the best outcome from your patient. and that's why the course scheme is designed like that. We need more people to join. Joint replacement is a surgery which is increasing in leaps and bounds. You will not believe the last year alone in India, we have the total, in spite of COVID, we have done around 3 lakh joint replacement in country. It is supposed to reach to around 1 million in next 3 years. And by 2030, India will be doing maximum joint replacement in the world. The way it's rising. So are we prepared? Are doctors prepared to do so much of volume of surgery, which is a life-changing experience? I always say in Hindi, we say ये ऐसी surgery है, when you operate, you get money and you get blessings both. Yes, trauma is our bread and butter. You will not get blessings because they are damaged people. They think the originality has been lost. Yet you are trying to restore the original lifestyle to them. So you get blessings, which is very important. And definitely you can share this. Once you see your patient walking, the amount of happiness a surgeon gets is not, you can't calculate with the money. So friends, this will let the conference going, and I'll start by the first session for which Vishal is there. Dr. Vishal Agrawal will conduct the sessions. So friends and youngsters will be there, and some of them are there in the virtual workshop. So it's just one sentence. For the first time, we are holding a virtual knee training workshop. It is a beautiful experience. We have been playing with this Oculus device in our city now, and we are starting it for the first time here, where you are transformed into an operation in a virtual world. The patient is lying in front of you on a table, your hands are working, you use instruments, and there's a guided protocol or unguided. You can use a guided protocol where the guide will keep on flashing. If you do something wrong, or do it like this. So they will keep on guiding you. So you can get a feeling of how you work on a patient. And then you can follow it up with the actual instrument you see on the table, which will be supplied to you. So this is a different world, but this is only part of the training protocol. After that, you must go and work with a surgeon to see actual surgery happening. Then you can go to the field and start your own cases. So this is like we started in 2005 with a resurfacing surgery. Now this time we are starting with a virtual platform for doing joint. So again, first to our credit, our courses credit, and our team's credit. Thank you, and let's have a good rollicking time ahead.
Thank you very much.
We should start now, I suppose. And to start the first session is to deal with how I did complex primary TKR cases by regional arthroplasty surgeons. And I invite Dr. S. Prasad sir to moderate the session, Dr. Dhansekhara Raja sir, Dr. Anupam Srivastav, and Dr. Mudit Khanna sir. So please come on the stage.
Starting with the first session, and welcome Dr. Maheshwari. This is a session where our panel will judge our cases. Friends, as usual, we are going to give a prize in the knee session and a prize in the hip session. So 1, 2, 3. So which is the number one cases which is presented? So it becomes a competitive session, and our panel will give them marks also. So we start with the first case, which is by Dr. Gaurav Gupta, and he's a young surgeon from city where I practice, and I know his capabilities. He's a multi-talented surgeon. Dr. Gaurav Gupta, please come to dais.
of 75 years female, elderly female, presented to me with acute onset severe pain on the left proximal tibia around the knee, and it was so severe pain that she was unable to bear weight on the affected limb, and she came with partial weight bearing with walker. And once I examined her, she has a definitive tenderness on the proximal aspect of knee. X-ray was done. It showed severe osteoarthritis of the knee. Definitely it was not a standing view because she could not stand. And well, no other finding was there on the X-ray. But yes, based on the history and examination, it was quite obvious that she was having some kind of stress fracture over the proximal end of tibia. So this made me think that now we are dealing with something which is there in the knee also, and something wrong in the proximal tibia. Yes, that could be a stress fracture. Well, stress fracture is a fracture which is caused by repeated force over the time, and it is a disorder quite commonly seen in the elderly female, which has associated valgus and varus with osteoarthritis. It's quite common in osteoporotic females. So once we made a diagnosis almost that she's having a osteoarthritis with stress fracture. Now the thing is, how should we move ahead? Well, in these there were three options which are quite common. One could be that we can give a cast immobilization for treating a fracture, and then later on move towards knee replacement. Another can be either we can fix. Yeah. Maybe sir, can I complete and then? Yes. Okay. So another option can be either we can go do a fixation for a fracture, and then in the second stage we can move towards the knee replacement, or we can simultaneously do both manage both the things with knee replacement with a long stem tibial component. So the definitive answer to this is again lacking in the literature. But whatever we should do, one thing was clear, that I have to make her mobile early because she is an elderly female. We should do something that should treat the fracture also. Fracture should heal, and that should treat her knee also. And so based on these, total knee replacement with a long stem seems to be a reasonable option. So I went forward to do a knee replacement with a long stem tibial component. The arthrotomy was normally the procedure was done similarly with the medial parapatellar arthrotomy. The cuts were taken as a usual manner. Reaming was done carefully, not to breach the cortex. Cementing was done over the tibial base plate. The cement should not go at the fracture site. And once there was a good stability at the fracture site, made her joint mobile from the next day, started initially non-weight bearing. At 15 days, removed her stitches, allowed partial weight bearing walk, and at 10 weeks, the fracture healed. Radiologically, in all the cortices, the fracture was healed, and clinically, she was having good range of movement. The extension was around 0 to 5 degrees, flexion was 100 to 110 degrees, and still this is around 12 weeks. At 12 weeks, reasonable range of movement. She was walking without support at 3 months. She has stopped all her pain medications now, and she is walking quite comfortably now, without any limp and much discomfort. Again, she sent a video she made herself while her granddaughters at school She was enjoying celebrating. So now she is reasonably doing quite well, doing her routine activity, starting socializing herself. So at the end, yes, presentation of proximal tibial stress fracture is not infrequent among elderly patients due to poor bone stock. Clinical presentation of them are usually sudden onset pain without history of any acute injury. One of the hallmark physical finding is focal bone pain or palpation. But that again depends on the location of stress fractures and the time of presentation. X-ray of these stress fractures may not be usually helpful initially in demonstrating abnormality. However, with the advancement of disease, radiographic change can help to visualize the periosteal bone formation, horizontal or oblique linear pattern of sclerosis, or a frank fracture line could be seen later on during the course of disease. So optimal management is still not very clear. So according to our finding, patient with stress fracture of proximal tibia with concurrent severe osteoarthritis can be managed with a total knee arthroplasty with stemmed component. The stemmed component that should bypass adequately through the fracture site. A long stem TKA bridging the fracture site has the advantage of restoring joint alignment and treating arthritis in one procedure, thus allowing fracture to unite and reduce knee pain simultaneously. It allows immediate patient mobilization without the need of any casting or splintage. However, possible reported complications in the literature are perioperative fractures during the tibial components insertion and a longer surgery time. So there are quite a few literatures that are available with ourselves. These literature shows that quite good results are there once they have a proximal tibia fracture with osteoarthritis. But again, sample size in all of them is not very big. So again, there is some dubious report. Well, but yes, long stem TKR as a single stage surgery can be a safe and effective procedure for complex arthritis with proximal stress fractures, proximal tibia stress fracture. Surgery corrects the alignment of the knee at the fracture site, causing union and early mobilization. And procedure has satisfactory clinical, radiological and functional outcome. However, yes, further studies, prospective long-term studies and with much big patient data should be there to be conclusive. But this is what I did. Thank you. Follow for last 2 to 3 years. She was ignoring her knee just for the sake she wanted to right time. When she wanted to do a knee replacement, she wanted everything to be perfect. But yes, suddenly one day she appeared to me with severe pain over the proximal knee and not able to walk. Yes, there was no history of any injury, significant injury. And on palpation also there was a definitive tenderness that was present. She could not bear weight. So it was quite obvious for me that to make a diagnosis of stress fracture of the proximal tibia.
Excellent presentation, Dr. Gaurav. How you calculated this axis? You haven't taken this bone scan or ortho scan, hip with knee and ankle X.
Yes. Firstly,
that is important, I think, so for any stem preference.
Because the stress fracture, there was not a gross deformity which was present over the fracture, so the cuts and everything was planned in a normal, usual manner. So I did not, fortunately for me, it was not a very displaced kind of situation. So I planned it in a usual manner, cuts were taken usually. The fracture became complete once I started, after all the cuts, I started preparing tibia. Then the fracture turned out to be a complete fracture which can be visualized in the post-op X-ray.
Dr. Gaurav, so from what I understand is that you were not able to see the stress fracture initially on the pre-operative X-rays, right?
Right.
And This X-ray was taken just pre-operatively, or you operated a few months or a few weeks after the initial X-ray?
It was once she presented with severe pain.
The question that I have for you is, how do you decide on the length of the stem that you want to put when you see a stress fracture?
Yes, this was one of the question, one of the doubt. But yes, once it was quite clear on examination what I took out, that it was somewhere in the proximal metaphyseal lesion or the metaphyseal diaphyseal lesion. So a long stem, I took a long stem to ensure that it will sufficiently bypass the fracture and it will have a good, reasonably good hold on the fracture. And fortunately, I did have a CM and I did had a visualization per op also. So it made my decision a bit easier.
Have you investigated the patient for osteoporosis or anything, spine X-ray or just
She
to
was on anti-osteoporotic for last 2 to 3 years. She was
BMD was done?
Yes, sir. That
Density
she was
was done.
taking. She was in the follow-up for many months. So all those medications were given. She was being planned somewhere down the line for TKR, but she was waiting for the opportunity, right movement. Well, she was waiting for it. So all these medications were given, and she was taking all anti-osteoporotics. Sir. Sir, sorry? Maybe a simultaneously plated I would have applied. Right. Yes, yes. So there's. Yes. Well, again, yes. A very good point which I was having also in my mind. Just, well, I've kept a plate too, just two things which. Because I did not put a plate, because per op I found that the fracture was a little lower down. Had it been more up, where in the metaphyseal region, when there was more chance that the diaphysis is wide and this rod will not hold it. Number one, this was my one point, and secondly, I gone through the literature and reasonable things are there that isolated, if you have an isolated stress fracture, then a fixation or stabilization would take care of it. But yes, that is. But yes, point well taken that we can do a simultaneously plating to be very sure.
I'll just make a couple of points, then I think I'll ask Dr. Maheshwari also to speak on this. This is a beautiful subject. Dr. Gaurav, you said fortunately, so you must remember, yes, luck always favors the brave, but it may not favor you all the time. So that's number one. Number two, if there's any doubt, yes, clinical judgment and the symptoms are very important in assessing, yes, probably something has happened and probably it is going to be a pathological fracture. But before surgery, it has to be confirmed 100%. If X-ray doesn't show you, don't shy away from getting a CT scan. So it will show you the profile of the fracture, and then you can plan better how much fixation you need. And
A
another
CT scan
thing.
or bone scan can help in these.
So that's one. And number two, I still think a derotation fixation is always coupling will give you a good night's sleep. So even a unicortical locking plate fixation will give you that sleep, that strength to mobilize the patient with support. And probably the length is again a debatable point, but I think I'll ask Dr. Maheshwari to put up a couple of points. What will be the take-home message? And Dr. Amit Rastogi, then Dr. Maheshwari.
I think one point I would like to make for the youngsters here, whenever you see a patient of osteoarthritis walking around for 2-3 years, coming to you, every time you tell him you want surgery, he goes back home, doesn't want surgery. One fine morning he comes in a wheelchair and he will almost pester you, Doctor Sahab, abhi admit kar do. Admit me right now, I can't even walk. And you are very happy surgeon, okay, finally the patient agreed. There is a bomb here. The bomb is something happened in last 2-3 days, which you must remember. And at least I remember on 3 occasions, different surgeons on 3 occasions have missed this fracture on the table. They've done TKR, they've come out and then there was a fracture. In one live demonstration, very bright surgeon actually picked it up before putting the knife. Why is this funny? You know, you go for a live demo, you don't even see the case, you see it in the OT always, and then the patient was postponed after having been draped. And I have seen my own self where patient is suddenly. So when a patient of TKR or needing TKR comes to you begging for surgery, sudden deterioration, something has happened. And normally we will have an X-ray from here to here. You know that mini X-ray. It will not even include upper tibia. So in my unit, all the time, all OA X-rays have to be mid-leg to mid-thigh. I don't want to miss even once. Number 2, have a recent X-ray. What they will do is they'll put up an X-ray which was done 1 month back and on which you have advised surgery, and now they want to get admitted. So have a recent X-ray all the time whenever there is acute deterioration. Number 3, in our country, I have at least had 2 patients who are secondarily infected. All these chronic OA joints are very prone for infection, tuberculosis. And suddenly when the patient was admitted in the ward, I went for a round and I found a funny swelling in the calf area and I put a needle and there was infection. So any sudden deterioration on a chronic arthritis has to be looked at with a lot of care. I think that's the only message I would like to give.
Before you, I'll just like to make a brief comment. Gaurav, you put one of the case reports in CCOT, which we have published, 20 cases we published 5 years back. Now recently I wrote a chapter on stress fractures in Mrinal Sharma's book, 45 cases. Basically you classify stress fracture into 2, intra-articular and extra-articular. Intra-articular where you have acute collapse of the proximal tibia and the metaphysis. Extra-articular is in the metaphysis. So when you're dealing with this, we classify into acute and acute stable and acute unstable. Acute stable, just you've not seen in the X-ray. You do an intraoperative osteotomy, it's still stable. Just use a long stem, intraoperatively it is stable. The stem has to go up to the proximal 1/3. It should be a relatively long stem. Second, acute unstable, you need to have a unicortical plate before you can do osteotomy. It's so unstable. So you do a unicortical plate, do the osteotomy, put the stem, then revise it to either unicortical or bicortical fixation. So this has to be discussed.
If it's unstable, we cannot take the cut once they we cannot do the balancing.
So if it's unstable,
so
always better to add a
Yeah.
plate. It's a Sir said, better to add a plate if it is unstable. But it's quite stable. You use a long stem. That is good enough.
Sir, with the intact
I think
fibula,
we'll go for the next talk.
sir,
Oh,
one question.
okay, Vineet.
With the intact fibula, do we really need to put a derotational plate? Because we'll be exposing the joint for another infection point. So if we are going to put a plate, you will be always predisposing that knee for infection chances. So do we really need to put a plate when the fibula is intact? One thing. Second thing, if we are putting a long stem, what I have seen, the patient usually complains of shin pain because the distal tip fitting of the stem. What can we do for that?
I think Vineet, both the answers have been given by Dr. Dhansekhar just now. So, in the detail you can ask. I'll ask
So in this same X-ray, you can see the tip of the stem is abutting the anterior cortex of tibia.
So if you have a fracture in this part, 100% you have to add a plate. Because it's a metadiaphragm. So you have it.
Because the biomechanics of stress fracture is just because of the abnormal weight bearing, abnormal weight transfer. So if you are correcting the axis of the weight bearing, it will unite automatically.
I told you, I think that's why I said that Dr. Dhansekhar has answered. And in surgical practice, common sense is important, but not all the right. And don't assume anything. There are published literature, go through that, and that's why Dr. I think, so.
Sir, one thing, what we can do for...
we are going for the next one. We will talk it again. Dr. Sunil has come or? Oh, hi, welcome. So next talk by Professor Sunil Kumar. He is a professor of orthopedics in a prestigious institute of Safai Medical Institute. And oh, that's interesting. Severe synovial chondromatosis. That will be interesting.
Umesh? Okay, fine. Thank you. Good morning, my seniors. And I would especially thank Dr. A.S. Prasad sir and his team for organizing this event and getting us together here again. And please accept my greetings from Safai. I'm presenting a case of a male, 47, around in 50s, and this was presented to me at around 2 years back with the pain, swelling and deformity over the knee, with some crepitus sound and instability, along with the impairments of daily living, so much so that his walking distance was decreased and was bedridden for some time. He also gave some history of trivial trauma for about 8 months back before presenting to us. Though there was no history of any fever or any other joint involvement in the body, and no treatment was taken or any intra-articular injections were given for that. In the past history, when he gave me the history of about 2 years back, he had a stroke incidence for which he was treated, but now there was no residual neurological or neuromuscular dysfunction. Along with that, he had no pre-existing comorbidities, no significant personal or family history, and no history of any drug or long-term medication for any reason. When I did my examinations, everything else was fine except for the palpable loose bodies along with the swelling, and there was varus deformity bilaterally, whereas there was 15-degree flexion deformity on the left side. The range of motion was restricted up to 100 degree and was painful. There was significant laxity both in anterior and posterior direction, along with the lateral collateral ligament laxity. There was no limb-limb discrepancy. There was a huge wasting of quadriceps and no neuromuscular involvement, and the systemic examination was unremarkable. Through radiological evaluation, I could see that the left side was more there was advanced tricompartmental osteoarthritis on both the side, but left side was more marked with multiple osteophytes and subluxation of left knee, along with the marked bone loss on the posterior middle aspect, with multiple loose bodies of variable sizes in the left side of the knee. So, having gone further with the routine investigations like CBC, ESR, CRP, rheumatoid factor, anti-CCP, ANA, serum uric acid, and other routine investigations were all normal. So, considering my examination, history, and radiological evaluation, as it is a monoarticular joint involvement without any history of infection and other reasons, in the settings of osteoarthritis, a history of trivial trauma, I suspected it to be a neglected post-traumatic synovial chondromatosis with advanced secondary osteoarthritis on the left side. I further went on to get the MRI done to confirm my diagnosis and other possibilities of infection and to rule out other pathologies. The MRI was suggestive of synovial chondromatosis with degenerative arthritis, which is a very rare disease, only in 1 in 1,000 people. 1 in 100,000 people. So it's a monoarticular disease arising because of the metaplasia and proliferation of synovium and producing lot of nodular swellings which get detached from the synovium itself and get nourished by the synovial fluid, and they grow in size. They may be of variable sizes, ranging from a small pinpoint to a marble size, and they also go under ossification and calcification. So the diagnosis was a bit obvious through MRI and radiological diagnosis. So how do I approach? What do I have options with this? So the options were very limited. Arthroscopic debridement and removal of loose bodies, high tibial osteotomy along with the debridement, or should I go for a total synovectomy and total knee replacement? Considering the limitations of the procedures and the technique, arthroscopic removal was probably not possible, not demanded at this point of time, along with the high tibial osteotomy. So I went through the extensive literature search, and I found this paper of Matthew in Journal of Arthroplasty in 2017. Here also they have showed high rates of local recurrence and complications following total knee replacement in settings of synovial chondromatosis. They have shown that the 5-year survival rate is, disease-free survival is 73%. Although they concluded that the total knee arthroplasty in this setting is a very good option to get range of motion and to make patient pain-free and comfortable and assist him in the activities of daily living. So I opted to go for open synovectomy, debridement of loose bodies along with the total knee arthroplasty, as the joint was not amenable to arthroscopy or STO-like procedures. Through a standard medial parapatellar approach, I performed the surgery and the synovectomy and debridement was done. The numerous corpora libra removed perioperatively were sent for histopathology, which further and went on to do further with the standard cemented total knee replacement. And I did not encounter any intraoperative complications. Synovial biopsy further confirmed the synovial chondromatosis. And patient was put onto the standard operative rehabilitation protocol, and he regained satisfactory range of movement and function. There was no residual pain, and he was able to carry out his activities of daily living with the ease. And this is the follow-up X-ray of day before yesterday, when he was visiting for some other reasons. And this is the video of day before yesterday when he was visiting. Before I play this video, I would like to add on to some information. Day before yesterday when he visited, I just called him to see, and he was almost bedridden for last 3 months because of his severe backache. But then I asked him if he could walk few steps. He has pain on both the sides. Right side pain is more, but the left side, he also has some pain, residual pain on the left side. Although I can see his knees are bent, he has some flexion deformity in both the sides, quadriceps. He is not doing any exercises right now. He was bedridden almost for 3 months. Now, how do we go about in this patient? I would like to know from the people here. Since this is my first experience with such kind of patients.
Dr. Sunil,
Sir.
you have presented very nicely, but the problem is that you have not evaluated the hip and spine because this gait was pre-operative gait. How was it?
Can I stop? Thank you.
Pre-operative gait of the patient. Was he,
Sir,
hip was normal? Because seeing this gait pattern, there is a hip is also involved.
So how many years follow-up you have?
Pardon, sir?
How many years follow-up?
Around 3.
3 years. And when is the last knee X-ray you took?
This is just the day before yesterday.
Knee X-ray is fine. But he's having back pain,
Back pain,
having
severe
radical.
back pain, along with radiculopathy.
Yeah, probably that is probably a new pathology he's developed. So you have to evaluate
Because
him
he
for.
was pain-free in between.
Yeah.
In between, when he came to for follow-ups. Yeah, I had.
So this is not related to the knee arthroplasty. I think knee arthroplasty is doing well. Probably developed a new pathology now with spine. So it is not related to this. Usually synovial chondromatosis, if you do a good radical synovectomy and joint replacement,
Here's the pelvic X-ray.
results are good. So this is a new pathology not related to arthroplasty.
No,
the
probably
knee.
not.
Yeah.
Dr. Oman.
Just a quick question. How painful was the knee preoperatively? Because was there an element of a neuropathic joint that we should rule out? That is number one. Number two, if his gait pattern was similarly broad-based preoperatively, we probably should have done a proper neurological examination, including the back, whether there's a cerebellar cause for this, ataxic type of gait. And also probably now, I think it is worthwhile getting, to begin with, a good proper clinical motor examination and then go ahead to look at the back and a neurological examination if he's having bilateral knee issues and stiffness, because he looks like he's in some sort of, definitely there's an element of nerve root irritation and spasm is what we can see.
Yes, sir. I had the possibility, as you said, neurological weakness, but there was no residual weakness or any sort of neurological problem just before the surgery.
Okay.
Though he had a history of 2 years backstroke, left-sided hemiparesis also, but it recovered completely.
So right now, if he's having both bilateral lower limbs, probably he needs a detailed evaluation now.
No, the other thing I agree with Dr. Anil, if you're evaluating a patient with gross instability, with a lot of newborn formation, you have to rule out a neuropathic arthritis.
Exactly.
The evaluation should include joint sense and vibration sense has to be assessed. MRI and nerve conduction study has to be done. If you had done that beforehand, probably you would have detected some spinal pathology also. So even this case, even now it can be a neuropathic arthritis. We cannot rule out, unless you do a spine MRI and nerve conduction study, you cannot rule out a neuropathic arthritis.
See, I would more or less agree with your approach that it was too bad a joint and asking for knee replacement, more or less. But there is a word of caution. Word of caution is he's too young, number one. He's from a rural background, number two. And you know, all these patients on day one, they are amazing. They do so well. It's a magic operation. Or what happens to this patient 10 years down the line, particularly when he's in a rural environment, has to be also looked at. Can you be conservative? Which means, what was the main symptom of this patient? If the main symptom was pain, I say there is no option but to do knee replacement. But very often the pain tolerance is huge, and generally osteochondromatosis, they're not very painful. They're just okay. So was there a possibility of doing an open debridement and a osteotomy to get the alignment right, give this young man another 10 years, considering his background? If he's a city-bound patient, I would have no second thought but do a TKR. But a rural patient, when you do a TKR, you kind of give a Mercedes to a juggy dweller, I always say. He has no way to go because he has to sit on the floor. And the revision of that knee is going to be disaster for him. So you are pushing actually him to a disastrous route. So if it is avoidable in a rural population, in a young patient, think of options. Even in a bad knee like that, if you do a good corrective osteotomy, good joint debridement, I'm sure it will last for 10 years. And then you can always do a TKR because then there is no other option. So considering age and the background of the patient, sometimes we have to scratch our brain and say whether we can still go on with non-TKR options. That's my only, I would do a TKR in this patient for sure. But if it is in city, 100% TKR, no doubt. Of course, we rule out neurological problem, etc. That's a fair comment. But just a warning, because a lot of people are from very rural background, and TKR is a very juicy operation on day one. You should always think what happens 10 years down the line for this particular patient. Thank you.
Okay, I think we'll go for the next, and I would request especially the presenters to stick to the time. The time is flashing right over across the podium because both the speakers overshot it by around more than 2.5 minutes.
Non-diabetic. So 56-year-old female housewife, non-diabetic, non-hypertensive, operated elsewhere for bilateral knee, 3 days apart in same admission. X-rays showed mild to moderate arthritis on right side, severe on left side. Index surgery was on 10th of November 17 and the second was 3 days later. These are the immediate post-op X-rays and the lateral views. The post-op was uneventful, no history of discharge, but she complains of swelling and pain 3 months later, was assured things will settle. She had occasional fever as well. So the 5 months post-op X-ray was like this on the right knee, the left was okay. 6 months X-ray. So 10 months, we can see some osteolysis on the underneath the tibial base plate. This was 1 year. The osteolysis has increased, swelling was there. She had occasional fever. She had pain during ambulation.
Did you do any investigation at that point? In 3 months, 6 months?
She didn't turn up to me till then.
She
So
presented
this was the time she came to me. Revision surgery was advised. She went back and took opinions. So 16 months from the index surgery, she came like this. So there was pus, shining underneath the lower pole of patella. Skin was about to give way. She was actually worried. She was not able to ambulate, and she was counseled and taken up for 2-stage revision. Cultures were sent along with gram staining, and since the skin 7 days later, when the stage 1 was done, the skin gave way. These are the intra-op pictures. So we did the first dressing change, and we found that the lower pole skin was actually not staying up. So we had a plastic surgery consult, and a post-op gastrocnemius musculocutaneous flap was done. And the spacer was put. The culture report was, the culture report showed Enterobacter, and we could isolate the organism. We were lucky in that. It was sensitive to meropenem, tigecycline, and it was continued for 4 weeks. The CRP and ESR values, the CRP fell to normal, but the ESR was still raised. And 2 months later, second stage revision was done. This is what we did. This is 2 years follow-up. This is knee extension. This was the flexion we gained. This is 2 years post-op gait. The knee was stable enough. And this is 3.5 year follow-up.
So for the time being, she is doing good. Thank you, sir.
If I seen this patient at 3 months, what would you have done?
I would have aspirated, sir,
And
under full sterile conditions.
if it is comes
And
as
blood
no,
values also.
if it is comes as no growth,
Sorry?
if it comes at no growth at 3 months,
I would have asked previously, if she had been taking antibiotics or not. Extended incubation, we should
instead of all many times you don't grow anything. So 3 months effusion, raise ESR, CRP, aspirate, no growth. What will you do?
probably a bone scan, but that would have,
No, bone scan usually is positive up to 1.5 years, so there is no role for bone scan.
I would have still asked for, I could see frank osteolysis underneath tibial base plate. So something is going wrong. She definitely needs revision, but I would have counseled her for that.
No, my question is whether you would have opened up and then debridement and implant retention at
I would
that
have
stage.
done that, sir.
So that could have been done at 3 months. Up to 3 months you can do that.
Spacer, which antibiotic you used?
So we fabricated the spacer on table. We use a femoral component and we put a cement on it so that we get a shape and the tip.
Which antibiotic?
Vanco, ciprofloxacin and gentamicin cement.
For gram negative? So
Gentamicin was
gentamicin is covering the gram. Vanco and
ciprofloxacin.
We have these vancomycin with tobramycin which can be used. And how long you gave post-op antibiotics after your revision, second stage?
4 weeks. Sir.
4 weeks IV, then
IV.
subsequently?
So CRP came down to normal. The wound was quiescent. She was actually financially very poor.
So what antibiotic you used in the revision surgery, in the cement?
Ciprofloxacin. Normal. Superset.
No, in the cement?
Cement gentamicin.
Okay. So again, you have an option to use Vanco with Tobra.
is a genta mixed with the cement. It is common. Okay, then it's okay. Pre-mixed genta.
No, I would just like to make a comment. I think whatever you did was excellent. Looking at the extent of the infection with which the patient presented to you, I mean, you must have done an excellent job with the debridement to get rid of the infection. And yeah, so overall, I think what you've done is superb. At 4 years or 3.5 years, if the patient is free from infection, then the debridement that you would have done would have been really good.
Thank you, sir.
Good job.
Thank you, sir.
Just a word of caution again, if I can take 1 minute.
Yeah, I think.
Because I'm very focused on young surgeons, and we have all learned this through hard way. When you have a patient of knee arthroplasty, running some swelling, some low-grade fever, you want to hide in the back room of your house. You don't want to think it is infection. Okay, you just hide anywhere. You get all the malaria test and your urine test, and fine enough you will find a urine infection in every patient, and you are comfortable that it's not infection, it is urine infection. Another 2 weeks gone, antibiotics loaded, now you are stuck. So anytime there is an unusual swelling, unusual pain, no fever, no ESR, no CRP, please do not start antibiotics. That's number one. First thing that you do is aspirate the knee. You can start the antibiotic next morning. So no signs of infection are confirmatory. You will have only pus discharge, then only it is infection, then you have lost the bus. So high index of suspicion, at least a quick aspiration before starting antibiotic will save you. More often than not, these patients will go here and there, somebody will start antibiotic. First thing I do is stop antibiotic. Wait for another 2 weeks before I take a culture. And that's the only secure way of finding out this. It is, and cell count. Not only culture is 99% negative in my practice. So at least a high cell count is a very high. And if it is very high, you have the best opportunity of opening it and debriding it right early, maybe within 3 months. That's where we hide, because we don't want to open, patient can't afford it, blah, 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 and then this happens. Two-stage revision. She is a poor lady. She was a poor lady. What happens now? Big operation, 2 operations. So we were hiding behind one small operation. Finally, she has had 2 operations, very unpredictable outcome. So I think we have to get out of this, and I have done it myself that way. But I've learned the hard way. If you suspect infection in arthroplasty, act early. Minimum is aspiration. Minimum is aspiration. No ESR-CRP business. And then only an act within 3 months. If you're suspecting infection, there's no harm opening the joint, debriding it, taking the plastic out. I think that step has to be done very, very quickly. Thank you.
Thank you, and we conclude this session, but yes, the important thing, I think, take-home message is never ignore the red flag. A well-functioning knee replacement, certainly after 3 months or 4 months or 6 months or a year, especially after 3 months, gets swelling and pain, don't ignore it. And when apart from that, you can see some osteolysis. Yeah, that's a big red flag. How to tackle? Yeah, I know, but you can't wish it away. That's very important. How to tackle? That's an important question. I think Dr. Hati, and we can share, I showed him an X-ray where one of my patients of MOM hip is showing osteolysis. I've just got some time. I told him to get chrome cobalt levels done, so that I can evaluate my idea of how I'm going to put up to revise it, because he is comfortable, he doesn't have any symptoms, but I can see the osteolysis occurring around the acetobula. So these are the tricky things, I know, but we have to take the bull by horn. So how to do it, we have to learn the tricks, and that we all do. Because the price the patient has paid and the surgeon has paid is tremendous. Like Dr. said, Dhanshekara, in 3 months, probably a debridement and change of poly would have served the purpose. Now we have a flap, a full-fledged revision knee. So yes, friends, that's important take-home message. And we conclude this session. We ask for the next session to be started. And again, a request to stick to time so that we can have lot more interactive questions. And I welcome Dr. Anup Agrawal, our friend here. Please, he's our UPO president. Sorry, president in waiting, president-elect. And also welcome Dr. Kapil Kursher, who has come all the way from Allahabad. So these are my old friends, the old team of our Kanpur Arthroplasty team. Thank you for being here. We start the next session.
I invite Dr. Hati as a panelist, Dr. Kapil Kulshresht, and Amit Rastogi as a panelist. The first lecture will be of Dr. Daksh Gadi. He is a young surgeon, full versatility which he has.